Good evening, everyone. I am Benita Olivier. I'm the Research Director of the Wits Institute for Sport and Health. Welcome to our webinar. This is our first WISH Wednesday webinar that we're hosting. And I would like to introduce the WISH concept to you, to those of you that don't know about it. So WISH is a network of clinicians and scientists in the Greater Johannesburg area, with expertise in all aspects of sport and exercise medicine, collaborating under the banner of the Faculty of Health Sciences, University of the Witwatersrand. So WISH, our Wits Institute for Sport and Health, offers our academic programs, specialist clinical services, and research support in the fields of sports and exercise. So we work closely with Wits Sport on presenting topics of interest, and this specific webinar series is part of our academic offering. Now, we would like to acknowledge the work that SASMA has done to share these webinars with their members. Thank you for that as well. Now, before we are going to jump in and before I present and introduce you to our honorable speaker, I just want to show you a bit more about our research endeavors here at Wits, at WISH. Okay, I'm going to share my screen. So we have a drive to get research going in the clinical areas, and therefore we call it our WISH Clinical Research Initiatives. And I know many of you are working in clinical practice, and many of you have had the urge to do research in clinical practice. So here's your chance. So we have our research priority areas: non-communicable diseases, prevention and rehabilitation, our injury surveillance, prevention and management and rehabilitation, pediatric physical activity, exercise and sport, geriatric medicine and exercise, women's health and exercise, human movement analysis and intervention, genetics in sport, and sports code specific research. So these are the priority areas that we decided to focus on for the next few years, but nothing is cast in stone, and we will adapt as we need to. So these research priority areas were formulated based on our national and international priority areas. Our sport, recreation, sport, arts, culture and recreation department have got certain strategic goals, and we've ensured that our focus is aligned with these goals as well. For example, an active nation. Yes, we want everybody to participate in physical activity so that they can benefit from the health benefits of physical activity. We want to encourage a winning nation, so that's the performance side of sport, and there's the sport and recreation sector to be adequately transformed. Then we have our sustainable development goals and our Department of Health and medium-term strategic framework priority area outcomes, which summarize it as a long and healthy life for all South Africans. Our research also focuses around the Department of Science and Technology, the grand challenge, the bioeconomy, health innovation, and our product development focus. And our research, one of the areas that we would like to strengthen is to strengthen our clinical research initiatives. So that every day in clinical practice, all of us are collecting masses of data. And often this data is locked up in cupboards and not analyzed for research purposes. So nobody learns from it, and that can be changed. So a few of the current projects that we are involved in: our femoroacetabular impingement syndrome international study, our fearless fast bowling cricket study, a concussion diagnosis study, epidemiological study at the Indian Ocean Games in 2019, and our big data in gait rehabilitation study in Africa. So these are some of the projects that WISH has embarked on this far. Now, if you're interested in doing research in your clinical setting, we would like to hear about that. You never know when an opportunity will come along to collaborate with us. And because we are affiliated with the University of the Witwatersrand, we are a core part of the Witwatersrand University, we can help establish that collaboration. And the Wits University has certain support structures. And all of us know one of the things that we always struggle with is I need some guidance in protocol development. My ethics application, how do I apply for that? Library access. We also have research management software, RedCap, which is an online system which is brilliant to manage data entry and processing. Then statistical support is another worry. Now, if you are interested in doing research in your own clinical practice, there's 3 options. You can either go to our WISH website and complete the short survey there, or you're going to be sent an evaluation form at the end of this webinar with a question if you're interested in doing research in your own practice. I will then follow it up with asking a bit more detail as to what you're interested in, what you want to do, or you can send me an email at benita.olivier@wits.ac.za. Okay. And I'm looking forward to hearing about you. Now, let's get ahead and let's introduce our speaker. So this is a really special lady. I've known her for quite a long time, and everybody that crosses paths with her only have good things to say about her. So Lorraine Jacobs is a highly experienced physiotherapist and an associate in a large multidisciplinary rehabilitation practice in Rivonia, Johannesburg. Over her career and in a variety of roles, clinical practice, specialized teaching, institutional and management in the physiotherapy profession, she has developed knowledge, skills, and competencies relevant to solving complex diagnostic and knowledge transfer problems. She is passionate about person-centered care, evidence-based practice, reflective practice, and critical thinking skills. She presents a series of webinars to train physiotherapists on risk stratification in low back pain. She has an MSc in physiotherapy and an MBA from Wits University, and she has attended many postgraduate courses in pain management. She has a postgraduate certificate in leadership coaching from Wits Business School and is a member of their coaching team. She is currently a member of the Professional Board of Physiotherapy, Podiatry and Biokinetics of the HPCSA. So please, we are going to hand over to Lorraine now, but before we do so, keep your questions safe. We are going to have a question and answer session at the end of this webinar. Please put your questions into the question and answers box at the bottom of the screen, and don't use the chat function for putting your questions and answers. We will monitor the Q&A box at the bottom of the screen. And over to you, Lorraine. Enjoy it.
Evening, everybody. Thank you to Benita and to Dr. Patricia as well for inviting me to join this WISH series of webinars. This talk emanates from a couple of articles we put onto the WISH reading list a couple of months ago on persistent pain in elite athletes. It formed part of the Olympic consensus statement on persistent pain. So a lot of the information that is in the presentation does come from those presentations, but there's a bit more from my own clinical background, my clinical experience. So I hope you're going to enjoy this evening. I'm going to share my screen. And so my talk is on persistent pain in athletes, contemporary pain approaches. So pain is one of our protective systems. It's only one of many of our protective systems. It's an output of the brain. It's a response of an individual to their context and perspective of evidence of danger or safety. The brain will assess whether a situation is a safe situation or whether it's a dangerous situation, and it will decide whether it needs to respond. So it also changes our behavior. So our protective systems are pain, our motor system, sympathetic system, immune system, and pain systems. So when pain persists, what has happened is that the protective systems have actually learned about pain, and they get better at experiencing pain and responding to pain. But this is not necessarily helpful. I'm sure if at some stage you would have encountered Pavlov's dogs, where they were presented with a bowl of food and they salivated, and then the bell was rung, and then eventually the bell was rung and they weren't given food, but they continued to salivate. And that is basically what happens with us learning about pain. And it is as a result of the function, structure, and chemistry of the nervous system, including the brain, changing the way in which pain is processed. So pain can be modulated or wound up and down by many factors, including our thoughts and feelings about pain, and unhelpful thoughts and beliefs, such as the belief that movement may cause more tissue damage and worsening of the pain, or a sense of helplessness and hopelessness will tend to modulate pain up, wind it up. And the longer pain persists, the less predictable the relationship is between pain and the tissues. So one of the things that is really important to get an understanding of is that tissues don't have pain receptors, and there are no pain pathways in the nervous system. We have nerves that are loaded with danger receptors. These are mechanical, chemical, and thermal that can be opened by a potentially dangerous change in their environment. And the nerves on which these sensors or danger receptors are called nociceptors. Noci is noxious. So noxious is dangerous, bad, potentially bad. And then if enough sensors are opened, the signal is triggered on the nociceptor and a danger message is sent to the spinal cord. The problem with pain is that we feel it in our body. Pain is the only protective mechanism of which we are necessarily aware. There are others, but pain is the one that tends to be the predominant sensation of awareness. And it's clearly felt in the body. So from a patient's viewpoint, the distinction between the body and mind may be impossible to grasp. So where does the pain clinician fit in? So we have the sports medicine team that is involved in acute diagnosis and management targeting strength, fitness, skills, performance, musculoskeletal recovery, and return to play. And then you have the pain physios, which I'm a pain physio, but I am a musculoskeletal physio, but I work from a behavioral psychology and a neuroscience informed perspective in order to identify the psychological and behavioral factors that contribute to the persistence of a person's pain processing mechanisms. And my aim is to develop an individualized, patient-centered plan with them to return them to their valued activities. And I do this within the multidisciplinary team. And my core competencies are focused on skilled communication and listening, behavioral psychology, targeting the mind-body connection between thoughts and feelings that influence behavior, and the persistence of pain. Pain neuroscience to help people make sense of their pain, movement analysis, which is a core physio skill, and I use a multidimensional clinical reasoning framework to identify the modifiable factors associated with pain, and then collaborate with the patient on an individualized treatment journey that includes making sense of their pain, using movement and activity to recalibrate the pain system. So I try to stabilize the protective systems by targeting their plasticity. I'm sure you've all heard of neuroplasticity and adaptability to calm the system down before we can build things up. So I've got the coolest tool in the box, neuroplasticity. It's got you into this and it can get you out of it. So everyone that is involved with an elite athlete with persistent pain needs to understand how pain works as a complex protective response to potential danger. The player is always in the center of the focus of attention. But we've got sports medicine, we have pain medicine. The player has a coach, squad, family, fans, and other members of the multidisciplinary team. It's really important that the messages that are shared by all the members of this team should always be consistent. If the patient is getting a message from one that persistent pain is a neurophysiological problem, and from somebody else that it's an orthopedic problem or a tissue-based problem, it creates dissonance for that person, and they don't know who to believe. And we've already gotten a wound up, upregulated nervous system. It doesn't need any more concerns. So the plan for this evening is to talk about tissue, injury, healing, and pain mechanisms and processing. We'll look at some key concepts of assessment of pain mechanisms, of clinical reasoning, and of management. We'll look at some special considerations for athletes. And I've included the weekend warriors in this because those are the patients I tend to see more. So and 2 elite athletes, and then we'll also look at a case presentation. So I said a very provocative statement in the blurb for this, the webinar, that once tissue healing has occurred, pain no longer has a causal link to tissue damage. So that's one of the things that we are going to unpack today. Sorry, my computer seems to have got a life of its own. So, tissue healing and pain. I'm sure you're all familiar with this diagram where there's an injury. We have a tissue response to the injury, the initial inflammatory response. We then have a remodeling response, well, a fibroblastic response, and then a remodeling response. And the pain response tracks that. So initially we have an increase in pain, and as tissue healing occurs, so the pain reduces, and by the time tissue remodeling has occurred, the pain should have gone away. And so we stop feeling the pain before the tissues actually stop healing. And healing is an irresistible process. Tissues regain their strength. Even if they don't look the same, the change is well adapted. So we call this adaptive pain. And this allows for optimal loading and a return to performance. But in some cases, pain persists beyond healing, and we call this maladaptive pain because it is no longer useful. The pain is past its sell-by date. It's not needed to protect the tissues any longer. And so what we want to find out are what are the drivers of this process. It can be ongoing overload, underload, neuropathic pain, or nociplastic pain. So some of those terminologies might be new to you, and we'll deal with them in quite a lot of depth. And it affects about 20% of people. It varies, but it's between 15 and 20% of people. And the output of persistent pain is emotional distress, functional disability. It interferes with activities of daily life and participation, and it causes behavioral change. So pain mechanisms and processing. So the systems that are responsible for the initiation, maintenance, and perception of pain are firstly the nervous system, which we have 3 different types of pain, which can be individual or can be a mixed presentation of nociceptive pain, neuropathic pain, and nociplastic pain. We also have the motor system, and we have the psychosocial system, and they're all involved in the maintenance of pain. And we also have in our sports and our athletes, we have an additional layer of complexity where they have their own expectations and beliefs. They have a team, they have family dynamics, they have potentially financial concerns, they have fans that they wish to keep happy, and they have coaches and management who have their own agendas in terms of the team and the players within the team. So firstly, we're going to look at nociceptive pain. Injury, inflammation, or even a mechanical irritation can activate nociceptors in the periphery, which nociceptor signals are then relayed up the spinal cord to the cortex through ascending nociceptive pathways. And when they arrive at the brain, multiple centers are triggered simultaneously to respond to the question of how dangerous is this really? And this may or may not result in pain. I'm sure you've all had the experience of seeing a bruise and wondering where it came from. So the sensitivity of the system is changing continuously. Within the central nervous system, nociceptive signals are under constant modulation up and down by cortical and brainstem pathways. So this can be facilitatory or inhibitory and can modulate or be modulated by emotional, sensory, and behavioral components of pain. So nociplastic pain is probably the one that potentially a new word to you. It's a fairly new definition. It used to be called central sensitization, but that has its own implications. So noci, noxious, again like nociceptor, and plastic because it changes. So it's pain that arises from altered nociception processing. So there's no damage to the nerve. It's just the processing that has changed. And it can be caused by increased central excitability, so the brain being excitatory or decreased central inhibition. So there's no evidence of actual or threatened tissue damage, which causes activation of peripheral nociceptors. There's no evidence of disease, and there's no lesion in the somatosensory nervous system. So the altered processing is usually in the central nervous system, and it's typically a chronic type of pain, and sometimes it's on a whole spectrum. So you've had persistent pain ranging from your musculoskeletal through to fibromyalgia, which is also one of those pains that we sort of battle to find a cause for. And then our last type of pain is neuropathic pain, which is a lesion or disease of the somatosensory nervous system. So it's actual nerve damage, and there's usually some peripheral trauma. And the pains that you experience in this are weird pains. They're spontaneous. They can be what they call ectopic pains, or allodynia. Allodynia is when a normal sensation becomes painful, or local hyperalgesia, where there's a painful experience is enhanced. And then we have psychosocial factors, which are basically factors that result in vulnerability of the person or resilience of the person. So an example of resilience is self-efficacy. A couple of examples of vulnerability might be people who are fear avoidant, or who are catastrophizers, or who have a sense of helplessness in terms of how they manage their pain. So these factors make them more vulnerable to persistent pain, whereas self-efficacy will make somebody more resilient to persistent pain. And then the movement system can also be part of the pain generating system. So movement changes can be on a spectrum from subtle changes to complete avoidance of function. That can be the effect of a nociceptive input or the cause of a nociceptive input. So we need to be able to assess these pain mechanisms to see what the contribution of each of them is to the development of persistent pain. So in the assessment, it's always useful to get the patient perhaps to complete the body chart, to note, to mark on the body chart where areas of pain are, to describe those areas of pain, to give them a value out of 10, to get them to reflect on their pain before we even start treatment. And then also to use a screening tool. So I've got here the START MSK tool. You can also have the Orabro. Both of those screen for biopsychosocial factors. And it's quite useful to have a scanning tool before you even start to see, is this going to be a very complicated patient, or is it going to be a simple patient? And then, of course, we always have to exclude our red flags. So malignancy, infection, inflammatory disorders and fractures, and any specific pathology. So any progressive signs of nerve root compression. Nerve root compression per se is not an indication, not a risk factor for treatment, but if there are progressive signs such as loss of tendon reflexes or loss of muscle power or loss of sensation, this could be a potential factor to take into consideration, or cardiac equinus, so where we have loss of bladder or bowel function, or saddle anesthesia. So as part of our assessment, we need to establish a very strong therapeutic alliance in order to build rapport with the patient. And this is based on therapist empathy, mutual respect with the patient, collaboration, and communication. So what we need to find out during the interview is the pain history, the context of the injury, the context of the pain, including any previous history of the same injury or similar injuries, what the pain provocation and easing responses are, which will give us an indication of the type of pain, an individual's thoughts and beliefs about their pain and how does the pain make them feel, how do they behave when they have pain, and what does it stop them from doing, so their functional activities and restrictions. We also need to know their general health issues, to know if there are any comorbidities, and their goals. Are they their personally relevant goals, any barriers to these, and their expectations. So to the pain assessment of the nervous system. So this remember, just a quick reminder that we're looking at nociceptive, neuroplastic, nociplastic, motor systems, and psychosocial issues. So identifying nociceptive pain, this is the easy one. It's associated with actual tissue damage and inflammatory conditions, and remember, it's a normal somatosensory nervous system. So there's a history of injury, it's a well-localized pain. The patient can normally put a finger on that pain, and pain is provoked and relieved by specific positions and movements. So the pain behavior is consistent and predictable related to movement. Nociplastic pain, on the other hand, is widespread and more poorly defined. It's a disproportionate mechanical stimulus pain response. There may be sensitivity to pressure, cold, movement, and loading. The history is that there's no defined pattern. It can be acute, chronic, can be traumatic or not. The patient may have beliefs like hurt equals harm, or that 100% relief is required before resuming activity. They have exaggerated or inconsistent pain behaviors, sympathetic responses, unexpected movement responses. They may have depression and anxiety and stress, so we could test that with a scale, the DASH scale 21. Pain, or they might be pain catastrophizers, we'd use the PCS scale, or they might have fear of movement or re-injury, so the fear avoidance questionnaire or Tampa scale of kinesiophobia. You might want to identify resilience factors, and we might see preference for avoidant or passive coping behavior, an all or nothing type of thinking that they've got to be better before they can go do anything. Neuropathic pain is caused by a lesion or disease of the somatosensory nervous system. There's usually onset consistent with some form of trauma. Again, I said spontaneous or strange pains, allodynia, local hyperalgesia. So we could look at this with the LAND scale, the Central Sensitization Index, Pain Detect questionnaire, and then we could also do some qualitative sensory testing, which would include 2-point discrimination or pressure pain testing. And then we could have signs of clinical impaired neural transmission, so loss of reflexes, loss of muscle power and sensation, and there could be positive neurodynamics. So they're very often not responsive to NSAIDs. They may be responsive to the TCNAs or SNRIs, pregabalin or gabapentin. Just a word on gabapentin. GABA is a neurotransmitter, and it's the brake in the nervous system, whereas glutamate is the accelerator. So psychosocial factors. So the athlete's beliefs are important considerations, their own beliefs about the nature of their problem, the condition of their tissues, the risk of major injury and its consequences, which is particularly important in elite athletes. They might have ideas of what treatments and how certain treatments might work, and the risk that injury poses to their performance and their life outside sport. And these are all very potentially relevant answers. So we've talked about resilience factors, we've talked about vulnerability factors. And here is a very nice article on recovery and sustainability, the things that drive patients into this disability and depression, persistent pain, and the things that help assist patients to get out of this vicious cycle of persistent pain. So mindfulness, acceptance, optimism, positive view, values, and a good social support system. The movement system. So we need to do a thorough physical examination as always, and this also can reassure the patient that the tissues are sound. We need to explore the impact of pain on function, daily activity and movement using the appropriate tests. We look at the patient's pain behavior. During the tests, we look at their confidence with movement and activity, the quality of movement. We also observe the kinetic chain during the movement to identify compensatory patterns. We would need to review the training load and periodization. And we could use a self-report questionnaire on function and disability, including the Rowland-Morris, perhaps for low back pain, neck disability index, the HOOS, the COOS, the DASH, any of those, depending which are appropriate for the area. So how does the movement system contribute to pain? So persistent protective motor strategies lead to learned motor patterns that overprotect sensitized tissue that is no longer vulnerable, and they may prevent optimal performance or compromise health of other tissues. So we can have different types of movement dysfunction. We can have an impairment of movement, so restricted movement in the direction of pain provocation. The patient avoids those movements, or impairment of control, where the control of movement is poor, allowing for direction-related gives and restrictions, and often moves the patient into the pain and is pain provocative. We look for pain behavioral responses. So this includes patients who pull faces, frown, breath hold, groan. They may have avoidant behaviors, or they may have boom bust type of behaviors where they overdo things and then they have to rest for a couple of days afterwards. Hypervigilance, compensation. There might be the grin and bear it type. Or there may be deconditioning, a loss of muscle strength, endurance, or physical capacity. So these behaviors could be protective or helpful, so normalizing the behavior I'm sorry that for some reason everything's jumping around. So if they're unhelpful pain behaviors, they provoke pain, or they can be protective and helpful. So we want to also look at their functional behaviors. We observe their strategies that they adopt, what their safety behaviors are, what their communicative behaviors are, whether there are any sympathetic responses. So we could have breath holding or fast breathing or sweating. We want to look at their loading activities, whether they have strength and endurance. We might want to palpate while they're moving to see whether there's tissue sensitivity or muscle guarding or respiratory patterns. We might question them regarding their beliefs, feelings, body perceptions, and pain responses. And this approach will facilitate us to have an idea of what their sensitivity profile is. So clinical reasoning. So this is different from clinical reasoning in a musculoskeletal problem when pain is persistent. So we want to develop a functional diagnosis, because persistent pain, as we've now realized, is a complex phenomenon not predicted by a tissue state. So there are no longer any structural issues. So trying to confirm a structural diagnosis, including imaging, may be counterproductive, or maybe nocibic. Nocibic is when the patient's words harm the patient. They get this idea they get stuck on an idea of what is causing the pain. It could encourage catastrophic thoughts. So our traditional diagnostic approach would highlight what is wrong. So a complex multidimensional presentation needs a complex model, and a functional diagnosis functions on what can be done to support recovery. So I quite like the idea of a radar plot, which gives us a multidimensional profile of the patient's pain. So this one has, you can plot on there the patient's beliefs, their affective responses, their physical responses, pathoanatomy, lifestyle, social, pain characteristics, and health. So we would end up with a diagram that looks like that. So for example, their cognitive beliefs could be, my back is messed, there's wear and tear on x-rays, pain hypervigilance, low pain self-efficacy. Or pain characteristics is pain at rest provoked by flexion, loading, postures, movements, and activities. So these would be very functional pain responses. Or there's a radar plot that even digs deeply into the neurological factors, the neurological components of the pain response. So again, a scale that you can mark on. So it would give you a multidimensional profile of the patient's pain. So key concepts of management. So firstly, there's no quick fixes. This is not a patient that's you're going to see for a week and they're going to be better. You might be lucky and just hit a chord with the patient and they suddenly go, oh yes, and they can leave you with a whole lot of self-efficacy and understanding and a better pain response. But for most patients, it's a slow process. It requires patience, persistence, courage, and coaching. And the route to recovery is based on identification of perceived threat and then graded exposure to that threat. And the graded exposure can be both physical and psychological. So we want to educate the patient and their supporters about pain mechanisms so that everyone understands the reason for the biopsychosocial approach and understands the contributions of the various pain contributors. We want to do values-based goal setting, exposure without danger, pacing. We pace mechanical loading, training schedules, performance. We look at the acquisition of motor skills, and we could be looking at inflammation management, diet, sleep patterns, for example. So a little bit more about targeted education. It targets the patient's thoughts and beliefs about pain. So it's been shown that improving the understanding of the biological mechanisms that underpin pain and the implications for management enhance recovery. So we would aim this at athletes, but work with the team, coaches, and management as well, their social support network. So it's vital that the clinicians who are explaining pain should have a deep understanding of the subject matter. So this little iceberg comes out of Explain Pain. Supercharge is what you need to know and what you need to pass on. So you do need an enhanced understanding of the pain mechanisms and the psychosocial contributions to pain. So there's a recent study, and it wasn't that recent, but exercise therapy for patients with chronic musculoskeletal pain is often hampered by pain memories. So phase 1 was an intensive phase of neuroscience education, and phase 2 was exercise therapy to address movement-related pain memories by applying the exposure without danger principle. So special considerations for athletes, both from the weekend warrior to the elite athlete. So there's evidence that athletes have consistently high pain tolerance as compared with normal active subjects. Pain tolerance is modulated by psychological factors, their confidence in their ability to manage pain, and a willingness to participate in activities when pain is present. So they may have the effective skills for coping with pain, acute pain and minor discomfort during competition, but persistent pain requires a very different response. And that's it's a difficult concept to get across to people, that then when pain is persistent, it does need a different response. Pain may also force an athlete to make choices about training and competition that will affect performance. Pain also affects life outside sport. There's a lot of information on the impact of pain on diet, social behavior, and relationships, sleep, learning, and mood. And there are, not surprisingly, reciprocal relations, such as how pain affects sleep and sleep affects pain. So we need to, again, our therapeutic alliance is to explore all of those factors with the patient. And this comes out of the Mosley article, and it talks about the modifiable factors, conceptual change strategies. So that is, you will explain pain, psychological therapies, modifiable by physical therapies, nutrition, medical diagnostics. So really what we are doing, we are targeting the modifiable factors. So I thought I'd just present a very short case just to show you how I would approach the problem. So patient came to see me for recurring low back pain. He's an avid runner who, like many before him, was struggling with maintaining his love for running and freedom for both his mind and body. He'd consulted a physio, he'd had a couple of treatments, he hadn't progressed sufficiently to allow him to return to running. So he was given a set of exercises, he had weekly review sessions and a home exercise program, and he was told that the goal of his program was to fix his low back so that he could return to running. But he wasn't happy with this approach. He felt it was wasting his valuable time and funds because he felt his full context was not being taken into account. Importantly, he needed to tell his whole story of who he was, not just as a runner. So the question to answer is, what does life look like for you? Asking a person this allows them to explore their personal pain experience in their context. Their personal context can affect mood, the capacity of the nervous system to the motivation, intentions, and everything. So his story was about a person who had a life prior to marriage and family, and this was changed by being a husband and having 2 small children. He's got a demanding job. He's got a close relationship with a very competitive brother. He has had a previous episode of pain, and he wants to make sense of why his pain keeps on recurring and preventing him from reaching his goals. So he needed to fit his back pain into his context and into his life because running was really important for him. So his pain prevented him from returning to running, also prevented him from participating fully in family life, and was impacting on his work. So what I would do with a patient like this, there's a lot of information that is given me. So I want to put it onto a, if I can get there, I want to say body chart, but that's not a body chart. Just to put it onto a whiteboard to list all those things and try and work out what the relationships in those factors are, or amongst those factors are. And then to work out what, so this is another model of the biopsychosocial model. So it's bottom up, which are generally the bio type of factors, outside in, which are the social, and then the top down factors. So for him, the bottom up factors, the bio factors, so he had an episode that happened after bathing a baby, he had a sedentary job, interrupted sleep, changed physical activity levels. His history was training for a marathon with his brother, who's competitive, and now he's only got 2 windows a week for 1 short run, 1 long run. Socially, he's married, he has 2 small children, a demanding job, and he manages a large team, and his wife also works full-time. He and his brother have a competitive relationship, and he and his wife need to work as a team. And then the psycho factors, it took a long time for him to recover last time. It's always in the back of his mind, it affects his training. He wants to be a hands-on dad. He needs to consider both his own needs and his wife's mental health and emotional needs too. He's got significantly less time to run, and running is his part of stress management. He manages a large team, so he has stress. So when we looked at his training load, is that his back pain significantly increased when his training load increased. So we can add that to his bottom-up factors. So my approach to this sort of patient, so we've made a bit of sense. With clinical reasoning, we'll track it put it onto a multidimensional profile. And then we start with education. So my approach to education is not the explain pain type of approach, which I feel is a very top-down approach. I like the making sense approach rather. So I draw it out with the patient. So we talk about nociception. We have a nociception line, we have a perception of pain line, we have a tissue tolerance line, and we have protective mechanisms. And this is now getting ready. So our protective mechanisms are the ones we talked about earlier. And in this, we have lots of space for activities. The protective mechanisms are just monitoring the system the whole time. They're like a little watchdog, just making sure that everything is fine and maintaining homeostasis in the body. So we have by using these lines, I can show them that the pain is a protective response. It occurs before tissue damage. So we can have hurt without harm in this case. So we then can talk about the process of injury and healing, which is the injury response and the healing response, and the normal pain response and recovery. But in some patients, we get the persistence of pain, and what happens here is that there is then much less space for activity. So there's frequently, this is where your flare-ups start occurring because that pain has never settled. And then also if you have a lot of stress, that line, that monitoring response, those protective systems become wound up, and we end up with that protective response increasing, and so there's very much less space. This area has now become really crowded, and that's when pain flare-ups can occur quite easily. So we need to develop in this patient a patient-centered plan to return to their valued activities. So there are no longer issues in the tissues. We stop feeling it before we stop healing it. Changes in the sensitivity of the nervous system. We look at the relative importance of the contributing factors, the patient's values, their goals. Are they realistic? Do we need to look at pacing or graded exposure? And we're building flexibility into the system, so stress management, for example. So this is my last slide. We want to increase load tolerance. So I've put this model together. So we have tissue tolerance. Initially, that's low when there's an acute injury, and it's high as the injury recovers. And then we've got vulnerability factors and resilience factors. So a patient with low tissue tolerance and low vulnerability okay. So I'm not sure. Am I still on?
Hi, Lorraine. It's Robin.
Yes,
you're still on.
Okay, but we've lost my screen.
Yeah, can you try and click share screen again?
Okay. So this is the last slide.
Great, we can see it.
Yeah, the current slide. Okay, so we talked about there's low tissue tolerance, so that would be in an acute injury. In a vulnerable patient, we've got to start looking at those yellow flags, fear avoidance, catastrophization, and deconditioning, so they don't become a chronic pain patient. So we want to increase their resilience by educating them, developing resilience, self-efficacy and optimism, low tissue tolerance and high resilience. We can go into optimal loading for stage of healing and comorbidities. And our aim is basically to have a patient with high resilience and high tissue tolerance. So that would be where the the management program would be moving towards. Okay, so that's basically what I have to say for the moment. There was a lot of content there, and I hope you managed to keep up. And I suppose, Benita, are there any questions?
Hi, I'm Lorraine. Yes. So thank you very much for this huge insight, as always. Things to think about and a lot of content. That's brilliant. But thank you for making sense of it in the case study. I think that was very valuable. Now, I like what you said, the neuroplasticity, it got you into this and it can get you out of that. So I think we all need to remember that. So the first question, have you ever been in a situation where you needed to justify the scope of physiotherapy, seeing that this approach to persistent pain in athletes is quite a behavioral approach? What's your opinion about this?
It's a question I get asked very, very often. And my response to that is that you can't separate body from mind. I'm still a physiotherapist. My focus is on returning a patient to functional movement, movement that they enjoy, their valued things, activities that they value. But when you're dealing with persistent pain and these plasticity changes, you can't separate the body from the mind. So you have to recognize those factors. You're not necessarily treating those factors, but you're taking them into consideration when you're planning your treatment process. And that's not to say that they've got huge psychological issues, because I do also work with a psychologist that I would refer to in the cases where if I recognized that there were psychological factors that were not just influencing behavior, but there were issues of on their own, so anxiety or depression or even coping skills. Sometimes patients just need another viewpoint on training of coping skills, which can be very useful. So it's recognizing those psychosocial factors, recognizing those behavioral responses. We cannot treat patients just as a body in front of us. We have to incorporate how they feel. So the person in front of you has, I always, my little thing is, I think, I feel, I do. So I think cognitive, I feel emotional, and I do is behavioral. So really, I have to, most of what we do as physios is changing behavior. And so if you don't understand the psychosocial side of changing behavior, you're not going to be able to manage those patients. And often my patients say to me, "Oh, you're more of a psychologist than a physio." But in fact, I'm nudging them in the direction of behavior change the whole time. I hope that answers that question.
Yeah, very well answered. So the follow-up question is that you mentioned that you're working with a psychologist, which is brilliant. What about the rest of your team? You are functioning as part of a multidisciplinary practice in Rivonia. How did you make sure that all of them go onto your same page so that you use the same type of language and the same type of approach?
Well, that's not always that easy. The physios that I work with too, obviously, we all have done pain courses. I think it's a philosophy, and they all had to come on the webinar as well. Well, they were all told to come on the webinar. So it's often not a generalized approach. I will get one of the bios. I know all of them, and so I will approach one of them, and we will talk about the psychosocial factors as well before handing them over.
Okay. Yeah, that's often challenging. I mean, communication with the multidisciplinary team becomes challenging in normal situations.
Yeah.
No, but that's good. We always should.
But it's nice when you're all on the same site, too.
Yeah. Oh yes. Yeah, that must improve.
You know, you can grab somebody over a cup of tea and say, right, this is this person, and this is what I expect, and this is what their expectations are.
Yes. So another question was that um, when you ask, and you touched on this when you answered the first question, when you ask patients about all these questions, and you almost moving a lot of patients perceive physiotherapy to be a physical profession, like physical therapy, you know. And when you're asking all these behavioral related questions, have you had patients that gave resistance to all these questions?
So because I work in the field that I work in, the patients that are often are sent the dustbin patients and the patients that they really are battling with. And so my opening, I will say to them right up front that I work very differently from any other physio that they possibly come across. And the first session, I might not even do a physical examination, because often by the time we've opened the communication taps, there's a long story to be told. But once you start sorting things out, and I do find that with explaining that sensitization, making sense of sensitization, is a very good inroad into putting their pain, their current pain, into perspective. So it is a bit of a cognitive change for patients, but I hope one day that we'll all be practicing like this, and that I won't be regarded as being a bit of an odd physio, but that everyone will be using a very much a psychosocial approach to treating their patients. Are we frozen?
It seems like we lost each other there for a bit.
Yeah.
But I think we got the gist of it.
Yeah. So one day, hopefully everyone will be practicing in a psychosocial milieu. It really, I was first exposed to just a little bit of history. So I've been a physio for 40 years. It's a long time. And after about 7 or 8 years of practice, I thought there has to be something, I'm missing something. Most of my patients I could get better, which I now know is a regression to the mean. Most of them would have got better anyway, but it was the group of patients that I couldn't get better that fascinated me, and that's what sent me on my journey of. And I was fortunate to be exposed to the biopsychosocial model in the mid-90s. So my exposure now has been about 25 years. So it's a gradual journey. It's not an immediate shift from being just musculoskeletal to being biopsychosocially focused.
And then Lorraine, so we've got a few more questions and quite a few questions coming in. Please keep sending them. So with regards to biomechanical or movement analysis, say for example, Paul, this patient that you, the case study that you shared with us, he's a runner. And what do you think running analysis may be perceived as, but you also mentioned the restricted versus controlled movement analysis, and that may be perceived as a biomedical model. How do you merge that into your biopsychosocial model, and how do you use the findings?
That sort of assumes that they are two different things. You're dealing with a patient, and so I don't see that it doesn't fit in. It's got to be part of it, because you're dealing with movement. That's what physios do. We do deal with movement, but we've got to explore the reasons, the contributions of other factors to movement dysfunction. And is it a result of it, or is it a consequence, or is it a cause, the movement dysfunction? And that's where it becomes really important. And I might not do that all on my own. I might actually as I said, I'm part of a team, or I would like to be part of a team. And so very often the patient may have a sports physio, and that we would work together and try and look at what those contributions are. But remember, we're dealing mainly with nociplastic pain. So we've got to, so we're not looking for issues in the tissues. We are looking for issues driving the sensitivity of the nervous system.
Oh, well explained. Thank you, Lorraine. Here's another one. Are there any differences between the management of adolescents and adults due to the neuropsychological developmental differences?
Well, there's two things. There's developmental differences in there, and there's different neuropsychological differences. So often when you're dealing with adolescent sports, you might be dealing with with family dynamics as well as, and coach dynamics and school dynamics, as well as the physical, the developmental stuff. So all of that has to be taken into consideration. And a younger person is more vulnerable to other people making decisions and choices on their behalf, and you need to take that into consideration as well, so that everyone has to come on board with the same approach. So
okay, very, very true. When patients ask in their assessment, how long will this take? How do you respond and manage their timeline expectations?
Well, what I said is it does often take a long time, that it takes persistence and it takes courage and commitment, and because we're dealing with behavior change. The difference is that I won't see a patient twice a week. I might see them once a week or once every couple of weeks, because we're on a journey of behavior change. So often so it's not so much a question of physical reconditioning as neurological reconditioning, developing that neuroplasticity, developing resilience, developing self-efficacy. So I would tell them right from the beginning, it's not going to be a short-term solution. It's going to take a while, and it's going to take a lot of commitment.
How do you calm a hypersensitive nervous system and affect nociplastic pain?
How do you
calm a hypersensitive nervous system?
Hypersensitive nervous system. So you got to start by finding out why it is hypersensitive. What are the drivers at that particular point? And you might want to get some pain control, some pharmacological assistance, ensure that the patient is getting good sleep at night, relaxation, breathing, to try and get that sympathetic nervous system to calm down initially, because there's usually a huge sympathetic response at that level. So that might be where your starting point is. So it might be getting some sort of medical help. It also might just be starting to work on creating some flexibility in the system to create a bit of space. Because remember, we're not dealing with acute injury. And having said that, you need to ensure that you are not dealing with an acute injury as well, that there hasn't been a sudden flare-up for a specific reason. But it's also very, very good as part of your, as when you're working with the patient to have a flare-up plan, because they are going to flare up. Because that is the nature of so the flare-up might be caused by a particularly stressful set of circumstances that is suddenly everything's coalesced, like lockdown syndrome. So many people had sudden flare-ups after lockdown syndrome because because, as what I termed lockdown syndrome, because of the behavior change that was suddenly forced on them, and the emotional change and the worries about COVID, the financial worries perhaps that they might not get a job, or they might not have a job, or they might get retrenched, or they might not be able to earn a living. All of those things can affect a nervous system and flare up a pain. And so those also need to be unpacked. And just being in a very calm environment with the patient and just almost talking them down to get them to calm down and to do breathing and relaxation, that's your starting point. But as I said, it's also good that when you are working with a patient like this, that they do understand that flare-ups are normal, that it's not a sudden, that their problem hasn't suddenly got worse, that it's a flare-up, not a re-injury or aggravation of an existing problem, that it is just it's a neuroplasticity thing.
So we have quite a few more questions to go through, but we're doing well. The use of Reiki in practice, how much of this is used to guide the patient as well with respect to physiotherapy?
Sorry, I missed the first part. What did you say?
The use of Reiki in practice. Reiki, a treatment approach.
Oh.
Reiki, yeah.
So I don't know too much about Reiki. I just know that we are trying to build resilience in a patient and reduce patient dependency. So any technique which is where the person becomes dependent on an operator, dependent on somebody doing something to them, takes away their self-efficacy. So if that is an approach that is something that is done to a patient, it's okay in the short term, but it's not a long-term solution.
Many athletes want a quick fix and do not have as much patience to deal with normal rehabilitation, let alone another form of treatment that may take even longer. How would you approach them and advise them to use this treatment? And I guess this is specifically athletes who want to return to the field as soon as possible after a flare-up.
Well, again, it depends whether there's an acute injury or whether this is now a persistent pain issue. It takes a lot of patience and questioning, and they've got to shift. They've got to make a shift into, so is going back on the field with pain, is it worth it to them? What is the value in that? What is the benefit? What is the worth of it? Or what? So it becomes unpacking values, unpacking goals, to have value-directed goals rather than short-term goals. Because getting back onto the field is very much a short-term goal. If they are willing to sacrifice long-term issues for short-term issues, that's obviously their choice. But if they want to address persistent pain, then it's going to take a longer time to address. Okay. So suddenly sometimes you have to nurse them through a season to get them into their off season, and then work in the off season to try and get them into. So it's a lot about goal setting and values. It's not a short-term approach at all.
Do you sometimes work with the coaches as well directly, or do you work with the coaches through the athletes in your current situation?
So I don't deal very much with top athletes in that sort of situation, but ideally you want everybody on the same page. You want everybody singing on the same hymn sheet. So it's you have to educate the coach too. You have to educate the family. You have to educate everyone who's working with that patient, because the problem, I mean, the field that I work in is really problematic, because the minute the patient leaves you, they are surrounded by information which may be very contradictory to what you've been telling them. So Dr. Google's out there, family members, a patient will come back and say, but my friends say I have to have an MRI, or I have to have this done, or I have to have that done, and this is the only solution for the problem. So you're dealing with this constant barrage of information the patients are getting, and sometimes you just have to say, okay, well, I'm sorry, but this is my considered opinion, and let's talk about it. Let's talk about the reasons why I'm saying what I am saying, and then you can make the choices.
Very wise words and insights. Are most of your patients you're dealing with, do most of them have lower back pain or neck pain, or do you often see chronic pain in the peripheral joints as well?
So I see predominantly lower back and neck pain, but there's more and more research coming through that persistent pain is not just a spinal problem, that it is actually it's a cause of disability. It can come from any part of any joint in the body or any structure. So my bias is generally lower back and neck pain, just because of the years that I've spent treating lower back and neck pain.
So with respect to biokinetics, and I know you're also working with biokineticists in your practice, eh?
Yes.
The treatment of pain obviously isn't in our scope, but yet we are dealing with patients who have pain and it is present, be it in the tendons, chronic residual pain syndrome, or fibromyalgia. The use of a biopsychosocial model and multidisciplinary approach is what the patient needs. How much of a neurocognitive conditioning is used during this with respect to neuroplasticity and metronome training?
It's a neurocognitive approach. So I'm not sure that is a specific approach, but and what was the other one? Metronome training.
Yeah.
So
neuroplasticity and metronome training.
So I don't actually know about either of those specifically, but if again my response to what I said earlier to somebody else is, as long as it's an approach which doesn't make a patient dependent, it builds self-efficacy in the patient. Anything that gets a patient moving, that they enjoy doing, that they're going to continue to do, is valuable. So but if it's something that needs constant supervision, needs constant guidance, then probably it's not an advisable in the long term. It's not a long-term treatment. But to go back to that first, so there were in there, the question was also about biokineticists treating patients with pain. I think you'll find in the new scope that it will be more acute injury rather than pain. So it's not realistic not to be treating patients with pain, because most people look for help because they have pain.
Okay, thank you very much, Lorraine. And I think, Lorraine, you had a few challenging questions and you had to think on your feet, which was very brilliantly done. Thank you for that. Now, I want to just share with everyone, Lorraine has mentioned that sleep affects pain and pain affects sleep. And you'll see that our webinar, our next WISH Wednesday on the 24th of June, is around sleep and exercise. So please see if you can attend that. I think it's going to be great fun. And we also have our 11th of June webinar coming up, Comrades Conquests. Okay. So Another point that I want to make, Lorraine has used the Kiel Start Back tool, or the musculoskeletal tool from Kiel University. And there's a scope for translating this tool into our 11 languages. So at the moment, the Kiel Start Back tool has only been translated in isiZulu, and there's an informal Afrikaans version on the website as well. So definitely, if anybody wants to do a master's into cultural adaptation of the Start Back screening tool, have a look on the Kiel University website and the Start Back tool and see the translations that has been done. It's a very nice and compact and very valuable master's topic that you can engage in. And now we are at the end of our questions and answers. You'll see that there's a link on this screen, redcap.link WISH webinar feedback. You can take a screenshot or a picture of this slide and type this into your, into your browser to go to the questionnaire, the feedback questionnaire. And this is also the place where you're going to indicate if you would like to get CPD points or not. So make sure that you either enter this link in your browser, or once you leave the webinar, you'll be automatically directed to the this page where you're going to be asked a few questions. What did you think about the webinar? And it will ask you whether you want CPD points or not, which is very much needed to answer if you want CPD points. Also, please follow us on Twitter and our WISH Facebook page. And again, you're welcome to email me for more information around the research side of things. So I think from my side, that is all. I would like to thank Robin Saggers and the WISH team in the background for setting up this webinar and all the organization that has been done in the background. And a special thank you to Lorraine. I think this is where in real life, and one day when we're face to face again, we would have given a huge applause, even a standing applause, because she's opened doors in our thinking that wouldn't have been opened otherwise. And we would have given a lovely physical gift, maybe a bunch of flowers. So thank you to Lorraine, and thank you to the whole team for making this possible. Remember to take a screenshot of this slide so that you can complete the questionnaire. Otherwise, if you're going to leave the webinar, you'll be directed to the feedback questionnaire and the CPD points that you can claim automatically. So thank you very much, and thank you everyone, Lorraine and Robin, and have a good evening.